Hello and welcome. Today I want to spend a few minutes talking about the anatomy of the palate. The emphasis on this discussion this morning is going to be about the palate in terms of its innervation and arterial supply, with a core reference to the anatomical components relevant to giving local anaesthetic. It's always a good model to look at palate in that sense about talking about local anaesthesia, because it makes sure you cover the entire topic. Now, when we talk about the fundamentals of the palate, there are two parts to the palate: the soft palate and the hard palate. As the name implies, the soft palate has no bony structure through it. It's purely a muscular and connective tissue structure, and it hangs as a curtain off the back of the hard palate, and its key is to separate the nasal cavity from the oral cavity. As opposed to the hard palate's primary function, which is about giving a surface to allow food to be broken down to form a bolus of food. And the hard palate also provides the support for the upper teeth that assist in breaking food down into a bolus ready for swallowing. So let's start with the hard palate and look at its anatomy. We're going to draw a simple hard palate here like this. A bit asymmetric, but we'll let that go. And on the hard palate we're going to draw some teeth. We'll do a central, a lateral, canine, first premolar, second premolar, first molar, second molar, third molar. And then we're going to contemplate the bones that make up the hard palate. And the hard palate is fundamentally made up of two bones. It's made up, the anterior 2/3 of it is made up of maxilla, a left and a right maxilla, obviously, and the posterior third is really made up of palatine bone. Now, just as a little trick to notice, that the maxilla actually sneaks back like this to actually surround the teeth. So all the teeth are embedded in maxilla, and the palatine bone forms the posterior 1/3 and has a little piece of palatine bone, and I'm overdrawing it here just to emphasize it, a little piece of palatine bone which sneaks in here to separate the sphenoid bones. Here's the lateral pterygoid plate and the medial pterygoid plate with the hamulus hanging off it. So this is the hard palate made up of maxilla and palatine bone. They have sutures running down the midline and sutures joining the palatine to the maxilla. The key foramini in this hard palate, and there are three. The first key foramen is towards the front of the palate, and it's called, under a number of names, I call it the nasopalatine foramen. Some people call it the incisive foramen, but I think nasopalatine is a clear word because it gives you some understanding of the nerve names that we'll talk about in a minute. And towards the back of the palate here, we find the greater and lesser palatine foramen. Greater palatine foramen, and its smaller cousin, the lesser palatine foramen. Now obviously greater and lesser just mean big and small. And so these are the fundamental foraminae that allow nerves to spread out over the palate. I want to be quite clear here. The nerves that supply sensation to the palate do not supply the pulps of the teeth. That is a separate story that we'll do in a little while. So if we redraw this picture, we'll just roll down a little here. We'll take the blue and we'll draw a larger palette like this. And for simplicity, we'll just put the foraminae in. We won't put the bones themselves in, greater, lesser. And the nerves that come out through these foraminae are all branches of the maxillary division of trigeminal. And the first nerve to talk about is called, well, it goes by a number of names. My favourite is the long sphenopalatine nerve, but its other names is nasopalatine nerve or incisive nerve. Any of those three will suffice, but for me, my favourite is the long sphenopalatine nerve, because that tells you where this branch of the maxillary division of trigeminal comes from. And just to be clear, it supplies the palate behind the incisors and canines. So in dental speak, we call that the nerve supplying the palatal tissues behind the 1, 2 and 3. It only supplies the palatal tissue. It doesn't supply the teeth themselves. It does, however, supply the periodontal ligament on the palatal surface of these teeth. The next nerve is the major nerve to supply the palate and is called the greater palatine nerve. It supplies all the way from the midline right out across the palate to the teeth, but not including the pulps of the teeth. So this is called the greater palatine nerve. And it comes out of the greater palatine foramen. This nerve supplies the gingiva on the palatal side and the palatal mucosa of the region from 3 through to 8. So in other words, premolars and molars. Now you can notice that it comes out of the greater palatine foramen. If you follow it back through the greater palatine foramen, it will go on to join the maxillary division of the trigeminal nerve. So this is the supply to the palatal region. Now the good news in this story is the arterial supply. The arterial supply is from the maxillary artery, and we'll talk about that in a separate video, but just to remind you that the maxillary artery, its branches come out with the nerves and spread out over the same distribution and have the same branch names. So for example, the one I'm drawing at the moment would be called the greater palatine artery, and this one here would be called the long sphenopalatine artery, and that brings blood to the palate. So this is the nerve and artery supply of the palate. Just to spend 3 minutes talking now about the mucosa of the palate. And remember, mucosa is always determined by function. The type of mucosa is always determined by its function. So if we think about the palate, it's going to have a lot of high stress, high load activity. So that mucous membrane needs to be a form that can accommodate these stresses. And that means we see it as masticatory mucosa. And masticatory mucosa has a keratinized surface. And that keratinized surface gives it its strength to resist the loads that are applied to it. It also gives it its light pink colour. So when you look at someone's palate, you will see that it's a very light pink colour. The other key features of this palatal mucosa is that it's very tightly bound to the underlying bony structure of the palate, and this is through very dense collagen underlying the mucosal surface. And the third key feature is that it has all these ridges running across it, and these ridges increase the abrasive ability of the palate to assist in breaking down food to form boluses that then can be swallowed easily through the oropharynx, down the laryngopharynx, into the esophagus and through into the stomach. So masticatory mucosa on the palate is a highly organised structure to resist the loads being applied and to allow this mucous membrane to facilitate the breaking down of food ready for swallowing. Alright, we're just going to spend 5 minutes at the end here thinking about local analgesia. If you were having to give local analgesia for palatal mucosa, the key question that everyone asks at the beginning is, where would you put the needle tip and inject the solution to numb different parts of the palate? Now, if you can keep this picture in mind, where you can see the greater palatine nerve and the nasopalatine or long sphenopalatine nerve, you can easily understand what you need to do. For example, let's just imagine that you wanted to work on the gingiva adjacent to the first premolar. Where would you put the tip of the needle to block action potentials as they run down nerves back to the brain? Sensory nerves. Well, the key is you could put it anywhere behind, posterior to the area that you want to work. So the obvious place to put it is about there, just a little bit posterior to where you want the action to happen. And that means all these nerve fibres that are running up here to the region you want to work on, they will be affected by the local anaesthetic solution, and action potentials will be blocked here and unable to get back to the brain. Obviously, you can put the solution right back here, because this would also block those action potentials on their journey back down this nerve heading back towards the brain. But in reality, you usually put it relatively close to the site you're talking about. Clearly, if you decided that you were also going to work on, say, an upper lateral incisor, a 2, you would then have to think about where the nerves from that area, let's assume you were working on the gingiva around that tooth, so let's just remind ourselves we're actually working here on the gingiva. You would remind yourself of where the action potentials flow from that gingiva back to the brain. And again, you would block it on that pathway back to the brain. So action potential from this region would flow back this way, down the long sphenopalatine nerve, so you would give it adjacent to where they enter the nasopalatine foramen, just here. So you can see the principles of how local analgesia would be given. It's given on the pathway of the nerves as they head back towards the brain. There's one other practical feature of giving local anaesthetic in the palatal region, and that is if you feel across the palate, if you feel from the teeth right across to the midline, you will find different levels of collagen tissue tying this palatal mucosa down. And the softest area is about midway between the teeth and the midline. And it is this area where there is a little less rigidness in the way the mucosa is tied down, where the optimum target zone for giving local anaesthetic is. So it's sort of a little trough that runs through here and all the way down back through the palatal area back here as well. And this little trough or target region is where the mucosa is less tightly bound. And when it is less tightly bound, it means when you try to inject solution, it's not as painful for the patient. So when you're aiming to give local anaesthetic in the palate, it's this soft zone, and usually we will feel that zone before we put the needle in. It is somewhere in that soft zone where you would actually inject the solution. And in reality, it takes a very small amount of solution to block fibres in the palatal region, a tiny, tiny amount of solution. Now, before we finish this video, I just want to add a little bit to the story. We've obviously focused on the hard palate because that's where we give local anaesthetic. But clearly, there are little nerve fibres that run out from the lesser palatine foramen to supply the soft palate as well, and this is called the lesser palatine nerve. And similarly, it has an artery system that parallels it called the lesser palatine artery as well to supply the soft palate. But obviously that's well behind where we have the last of the molar teeth, where we would be normally working. This is the 8, obviously. So lesser palatine nerve is not as interesting for giving local anaesthetic as the others. Thank you.